Welcome to IRG's Sports Medicine Update. I'm Tom Hutler, along with Shannon O'Kelley, physical therapist and president of Integrated Rehabilitation Group, and our guest, Dr. Richard Angelo, immediate past president of the Arthroscopy Association of North America and orthopedic surgeon from Evergreen Orthopedic Center.
Dr. Angelo, thanks for joining us. Being an orthopedic surgeon, I know that your world is osteoarthritis and a lot of it, because we're hearing about osteoarthritis a lot in the media, on the news. What is osteoarthritis, basically, for those people listening out there?
Well, Shannon, technically, osteo means joint. Arthritis component of it means inflammation. So anytime you have inflammation of a joint, technically you have arthritis. But what most people mean is wear and tear or degenerative osteoarthritis, which means loss of the tread cartilage that surfaces the bone and wear of that component.
And how does osteoarthritis, I guess, differ from, we hear about a kind of a rheumatic arthritis or other forms of arthritis. What is the difference there?
Sure. So inflammatory arthritis basically means that a systemic inflammatory component throughout the body may be autoimmune, where the body's own immune system is working against itself, may lead to degradation of that articular cartilage. So it's a systemic phenomenon, may involve many joints, as opposed to osteoarthritis, wear and tear often involves just one joint or several joints.
That's interesting. So osteo, basically, a lot of people, if you're basically upright and active, there might be a chance that you just wear your joints out.
That's true. I think for the most part, it comes with the mileage that you put on your joints, particularly your knees. But truthfully, some patients are probably born with 30,000-mile cartilage, and some patients are born with 50,000-mile cartilage because they maybe do about the same amount of activity, and one gets arthritis easier than another.
Okay, so patients ask me this all the time. Basically, why does our joints wear out? Why do we get osteoarthritis? What is that cartilage doing? And maybe why doesn't it repair itself?
Well, it's something of an oversimplification, but it's much like tire tread. That articular cartilage slowly will wear and break down just because of use. And articular cartilage has very little potential to repair itself, so that as it starts to break down and wear, that's a progressive phenomenon, and it can't actually heal itself as soft tissues typically do.
And so when it wears down, I mean, what they're doing now is they're doing these replacements, these total joint or partial joint replacements. And I know you've been doing this a little while, and I know you speak a lot around the country and internationally. How has the joint replacement world changed since you started doing it, maybe, 20, 25, 30 years ago? I'm not trying to kind of, set you up here for failure, but...
Shannon, I think 30 is probably the closest number.
Okay. You have a lot of experience, let's just say that.
Well, I think probably one of the greatest advances has been the ability to marriage computer navigation with robotic technology and the accuracy that brings. And so that's probably one of the greatest changes that we've seen. And it's very, very exciting to see patients with a less invasive procedure actually be able to get up and get more functional on a quicker basis.
Okay, so tell us about that, because, again, when I tell a patient, they're doing this robotic knee replacement or surgical procedure, people automatically say, well, is the robot, where's the doctor? Is the doctor in the room? So set that up for us. Describe that robotic procedure.
So maybe I'll step back just a little bit, Shannon. So what's done is a CAT scan is taken of your own knee, and basically slices are taken and fed into a computer. And so that computer knows exactly the shape of your knee, not just medium, large, or small. And then that information is fed into the computer, and on the computer we can take components and position them, orient them, rotate them, etc., to see what's best for your particular knee. And then when we get into surgery, we map out ligament tensions, and then we can reorient those positions to perfectly match the tensions that work with your own ligaments, so that that's done before any surgical procedure in terms of bone removal is completed. So that entire procedure is rehearsed on the computer, and once you dial everything in exactly the way you want it for Shannon's knee, then you lock that in. to the robot. The robot comes in, and I'm guiding the robot, and the robot, once that program is locked in, will only allow me to go within the confines that we've already accepted.
Wow. So that sounds like right there, what you described basically sounds like you're enhancing, one, outcomes for the patient and the surgeon, and two, efficiencies, and then just placing that component in that joint is going to be more accurate.
That's right. We've known for many years, Shannon, that the longevity of a partial knee replacement in particular is very dependent on the alignment and the positioning of the components at the time of surgery. So the more accurate that those can be, the more likely that that knee will last that patient a long time.
Okay, so you just mentioned something that, because when you and I broke into this business back in the day when I got started, it was just total joints. I mean, we talked about total hips, and right now we're talking about total knees. But you just mentioned partial knees. So let's set it up. What is a total versus a partial, and why would someone want a partial?
So we think of the knee in three components: inside toward your other knee, outside toward the outside of your body, and then the kneecap joint as it matches the thigh bone. So those three compartments. So oftentimes patients will have disease, quite a bit of arthritis, in only one of those three compartments, occasionally two. When that happens, then if you have the opportunity to replace only the diseased portion, you don't have to remove normal structures and normal tissue from those other areas. I think the second advantage is that with a partial knee replacement, you remove none of the patient's own ligaments, whereas the first thing you need to do with a total knee replacement is remove the anterior cruciate ligament. So it's a fairly significant difference in how the knee feels once you're finished with the joint replacement.
So a partial knee versus a total knee sounds like that's a decision made by the surgeon based on probably some studies. How do you make that decision? Who gets a total and who gets a partial?
So great question. That's made partially on the evaluation at the time of the office visit in terms of where the locations of pain are. It's made partially based on x-rays, where the disease is most evident. And then there's a final decision sometimes made at the time of surgery as to whether or not two compartments need to be replaced or only one, based on what the cartilage tissue looks like at the time of surgery.
So you're making this decision, and these people are coming in, and let's talk about a partial knee replacement, because that sounds like that's kind of a good option for a lot of people out there, because I know a lot of people my age, that'd be 50, everyone, and they have these kind of worn out knees, and I'm seeing a lot of people my age having these partial knees done. What are the outcomes? Am I going to ski? Am I going to run, jump, do what I did prior to this surgery?
Well, I think with a partial knee replacement where you retain all of your own normal ligamentous structures, most of the patients are very, very functional. I think anytime you have a joint replacement, whether that's partial or complete, it's certainly prudent to limit the amount of impact and pounding that you do. So I don't know that you'd want to become a half marathon runner with a partial knee replacement, but certainly in terms of returning to softball, soccer, skiing, light tennis, where you're not necessarily playing singles, those would all be very reasonable expectations for a patient with a partial knee replacement.
Is there any particular, are you using a certain computerized methodology or system right now in your practice?
There really is only one system right now that commonly marries the robot and the computer, and that's Makoplasty is the term for that particular partial knee replacement.
Do all hospitals and organizations have this particular device?
No. Evergreen Hospital was the first on the east side to have the technology, and it's really opened the avenues to bring patients the absolute latest and best in terms of joint replacement technology.
So what the good news out there, and the folks listening right now, is that in my practice at least, I see, again, I want to go back to a lot of these folks that have these worn out knees. And it used to be that when I first broke into this, you had to be like 65 or so to have Back then, I guess it was a total knee replacement. Are you replacing these and making these people more comfortable and maintain their activity like in their 50s now with these partial knee replacements and the computer technology?
Yes, I think you certainly do. But I always go back, Shannon, to 3 basic questions that I ask a patient to say, because patients say, well, am I ready? And I say, I don't know, but answer 3 questions sort of in front of a mirror. Number 1, is your quality of life unacceptably adversely impacted by your knee pain disease? Number 2, has it been a minimum of 6 months in that particular condition? And number 3, have you tried all other non-operative, less invasive treatments to get acceptable relief? And when the answer to all 3 of those is yes, I have, and I'm not really in a position where I'm at all accepting this level of limitation, that's a good time then to say perhaps you're ready then to consider a replacement.
Wow, excellent information. Thank you again for your time.
You bet, Shannon. It's always a pleasure.
If you would like more information on this topic, as well as how to contact Dr. Richard Angelo, go to irgpt.com and click on the Health Media tab, or go to Integrated Rehabilitation Group's Facebook page.